Now we are going to examine this lady who kindly agreed to participate in this demonstration. She is a 39-year-old primigravida presenting at 37 weeks of gestation. She was admitted from the clinic because she was found to have a Symphysio fundal height less than her period of gestation. So, let us look at how we are going to examine this patient. First of all, we have taken the consent and she kindly agreed to that, and we have exposed her, and if you look at it, we have exposed up to the syphisternum and to the pubic symphysis just to cover her pubic hair, and her hands are either side of the tongue. Now, on inspection, we can see the linear niagara, and there is very few striae gravidarum because of less distended or enlarged abdomen. Abdomen is enlarged symmetrically, and there are no surgical scars where we specifically look for surgical scars in areas. At the moment, I cannot see any visible movements of the fetus. Okay. Now, let us move on to the Symphysio fundal height. As we discussed before, we use either palmar surface, radial surface, or even fingertips to detect the Symphysio fundal height. And I want to reiterate, like even especially when the fundus is small, we need to detect it properly. Irrespective of the presentation, Symphysio fundal height is one thing, that basic thing that we do in the examination to detect the fetal growth, because we take the Symphysio fundal height as a proxy to the fetal size. Symphysio fundal height examination is a very important thing in our obstetric assessment. Whether the fundus is small or large, we need to stick to our principles of examination. So, here also we start the examination from the syphisternum. Here I am going to use my ulnar border to examine the fundus. So, I start it from the syphisternum. I gently come from top, slowly 1 centimeter by 1 centimeter in the midline, feel for the first resistance where we get the fundus. That is where I feel the first resistance. Now, when I get the first resistance, that is the highest point of the fundus, I want to make sure that is the highest point the fundus has gone up to. So, I move my hand to either side and feel whether there is any, the border is in the right place. So, in this lady, the fundus is slightly shifted to the left side. So, two things I can do. I can correct the fundus to the midline, or I can straight away measure the Symphysio fundal height from here to here. I am going to measure the Symphysio fundal height from the normal position that it is. Here again I am going to use the inches side up to avoid bias. I keep it here, and then I gently come into the midline using my thumb, feeling for the upper border of the pubic symphysis. And if you look at it, it is 31 centimeters, which is less than a period of gestation. Then I am going to move to feel for the fetus. So, I am going to look for the lower pole, where I am going to turn my body like that. I go for the anterior superior iliac spine, and then I press downwards towards the pelvis, looking at her face to see whether there is any pain. Now, I feel a hard mass which is deeply gone into the pelvis. I feel just the upper 1/3 of the possible head. Therefore, I cannot ballot the head. I can feel the constriction, and if I move up a little, I can feel the body of the fetus. So, I guess this is the head. However, I need to double check with the upper pole. So I'm going to move to the upper pole and do the same. Using my palms of the hand, I'm feeling for the upper pole like that. And it is parallel and symmetrically going up. Now I feel the breech, firm mass which is continuous with the body like that. Okay. While I'm looking, I move my hand along it, along the body. Same thing this way. So when I do that, I feel the back of the fetus on her left side, and I feel the knobby masses on the right side. So this baby is in cephalic presentation, longitudinal lie, and the back is on the left side, so therefore this is left occipital anterior position. At this moment, because I have already examined to see how much the head has gone in, I can also say this head is engaged, and if you are going by the fifth palpable, only 1/5 palpable per abdomen. And while I was examining the abdomen, I also felt the LICO volume. I think despite the fundus less than dates, the LICO volume is clinically adequate. But you need to know, clinical assessment of LICO is not a sensitive measurement of actual LICO volume. Right. The next step would be to auscultate for the fetal heart. So this is the right way to hold the pinard. We know there are Dopplers that you can straight away use. Here I am going to use the pinard. So I am going to stabilize the fundus with my left hand, and I imagine the baby's shoulder is somewhere in this area because the head is down, the breech is up, so back is in this direction. So I am going to keep my hand pinard over here, listen to the fetal heart. I can take my hand, and if I want to count, I take a watch and count for an entire minute to assess the fetal heart sound. I can hear the fetal heart sound, and that's regular. And at the end, we need to estimate the fetal weight. So we know this lady is having some fundal height less than the period of gestation. I suppose the baby is small, and then you assess by keeping our hands like that or even like that. I think this baby is somewhere around 2 kilograms for the estimated fetal weight. And once we've completed the examination, we close it and we thank her and make her comfortable. Okay.
Let's revise our knowledge on bony pelvis. The bony pelvis consists of two hip bones and sacrum. The two hip bones will articulate anteriorly with each other at the pubic symphysis, which is a secondary cartilaginous joint. The hip bone will articulate with the sacrum posteriorly and form the sacroiliac joint, which is a synovial joint. When we are looking at the bony pelvis, and especially the hip bone, we will find this hip bone made out of three separate bones. This is ilium, this is pubis, and this is the ischium. All three bones will come and lie and attach with each other at the center of the acetabulum. At the center of the acetabulum is displayed here. When we are looking at the hip bone, it is very important to remember some landmarks. Here in the ilium, anteriorly, we will find the anterior superior iliac spine, where the inguinal ligament will start. Anterior superior iliac spine will continue with the iliac crest. Coming down from the anterior superior iliac spine, we will have the anterior inferior iliac spine. From the anterior inferior iliac spine, we will have the superior ramus of the pubis. Here, we will have the pubic tubercle, where the inguinal ligament will attach. Then we will find the body of the pubis. The body of the pubis will continue down as the inferior ramus of the pubis, which will articulate with the ramus of the ischium and form the ischiopubic ramus. Here at the bottom, we will find the ischial tuberosity, which is very important bony prominence for the obstetric examination as well as for the sitting. When we are moving to the posterior aspect of the hip bone, here we will find the lesser sciatic notch. Then we will move upward where we will find the ischial spine. Again, the ischial spine is very important for the obstetric examination as well as for the procedures such as pudendal block. Here we will find our greater sciatic notch, and here we will find the posterior-inferior iliac spine, and here we will find the posterior-superior iliac spine, which will also again continue as the iliac crest. For the teaching and the academic purposes, we divide the pelvis into true and the false pelvis. This imaginary plane will pass anteriorly, starting from the pubic symphysis, then in the pubic crest along with the pubic tubercle, and then the pectinate line and the arcuate line of the ilium, passing through the sacroiliac joint and in front of the ala of the sacrum and the sacral promontory. So this plane will divide the bony pelvis for the academic purpose into a false and the true pelvis. This anatomical division, which is above this imaginary plane, is what we call as the false pelvis, which has a very little significance in the obstetric point of view, which will support the growing or the enlarging uterus. It is more important to know about the true pelvis, which is below this imaginary plane. Let's have a look at the true pelvis. For the demonstration purposes, I have removed the left-sided hip bone. The true pelvis is below this imaginary plane, which I described before. Here we will have the pelvic inlet. Then we will have the pelvic cavity, and here we will have the pelvic outlet. When we orientate the hip bone in the anatomical position, where the anterior superior iliac spine and the pubic tubercle are at the same vertical plane, we will have an inclination of this pelvic inlet of 55 degrees to a horizontal plane. But when there is a sacralization where the fifth lumbar vertebra will fuse with the sacrum, this inclination angle will increase. This will lead to a bigger inclination angle, more than 55 degrees. When you have a increased angle of this inclination, there will be a delay in engagement of the head of the fetus. Also, when there is a lumbarization of this L5 and S1, where the first sacral vertebra, which will fuse with the L5 vertebra and separate from the rest, this inclination angle will reduce. This will lead to an easy engagement of the head of the fetus. Let's go through the pelvic measurements. As I described before, we have the pelvic inlet, the mid cavity, and the pelvic outlet. At the pelvic inlet, we have the transverse diameter greater than the anterior posterior diameter. So this will facilitate the head of the fetus, if it is a cephalic presentation, to engage in the transverse manner. In the mid cavity, when you are looking at the pelvis, this anterior posterior, the transverse diameters are almost equal. But when you are looking at the pelvic outlet, we have the anterior posterior diameter which is greater than the transverse diameter. So during the vaginal delivery, there is a transposition of the head from the transverse position to the anterior posterior direction at the mid cavity. Let's briefly go through the normal and its variations of the pelvis. The gynecoid pelvis, which is the quite normal and the most common variety in the Caucasian females. Then we will have the android pelvis, which is more or less equal to a male pelvis. Then we will have the anthropoid pelvis, which resembling that of an anthropoid ape with a much lengthened anterior posterior diameter and a shortened transverse diameter. Last, we will have the platypoid pelvis. This is shortened in the anterior posterior diameter and increased in the transverse diameter. Let's have a look at the pelvic outlet. The pelvic outlet, we divide it into anatomical pelvic outlet and the obstetric pelvic outlet. This obstetric pelvic outlet is an imaginary plane starting at the pubic symphysis. On either side, we have the ischial spines, and posteriorly, we have the fifth sacral vertebra. This narrow pelvic plane is very important for the internal rotation of the fetal head, which will enter through the pelvis in the transverse manner if it is a cephalic presentation, and then at the pelvic outlet with this internal rotation will have anterior posterior direction. And this imaginary plane is important for the pudendal block. When we consider the pelvic outlet, the anatomical pelvic outlet, when we have a look at this, as you all can see, it is a diamond-shaped pelvic outlet anatomically. The diamond-shaped pelvic outlet is made by this pubic arch anteriorly and posteriorly by the tip of the coccyx, and then on either side is by the ischiopubic rami, these two, and then we have the sacrotuberous ligament. So the pubic arch, the ischiopubic rami, here we have the sacrotuberous ligament and coming with the tip of the coccyx, which will form the anatomical pelvic outlet. Thank you.